Excuse me. Dr. Beckmann has published over 50 peer-reviewed articles, primarily focused on surgical treatments of aortic pathology, as well as numerous presentations. As part of the Allina Health Minneapolis Heart Institute, his practice includes
Good afternoon. Thank you for the introduction. I understand there were some tough words in it, but you did pretty well. Germany, and last week I had a fall on my face, so I have an eyelid hematoma, so it's not from a bar fight, that's my disclosure. At work, every colleague asked me, hey, have you in a bar fight last weekend? I said, no, it just happened at home, so I'm taking it a bit easy now with the weather here. Yeah, at Abbott Northwestern Hospital, most cardiac surgeons offer, or all cardiac surgeons offer the full range of adult cardiac surgery, and some of us have some focus or special interest. My focus is aortic surgery. I trained at a place in Germany that has a long tradition and a big volume in aortic surgery, and it's actually a great opportunity here to talk about this topic today. So, how does this go? Maybe the big green button? Yeah, that's right. So, what am I going to tell you within the next couple of minutes? So, that's a quick outline of my talk. First, I want to just give you an idea of the normal anatomy of the aorta. The aorta is your main blood vessel in the body, and I think it's always good to start with the normal anatomy in order to stand some pathological changes or disease processes, and that would be my next point that I would like to present to you. Talk about some aortic diseases, that's primarily aortic aneurysm, as we have already heard before, and complications that can arise from it. Then I would like to spend some minutes on surgical options. What surgical options do we have to treat aortic aneurysm diseases, and what can we expect after surgery in the hospital and after the first weeks and month after it. So let's start with some anatomy. The aorta is your main blood vessel in the human body. It starts at the heart, and basically there's one valve that separates the heart from the aorta, and that is called the aortic valve. The aorta basically goes first north, then makes a curve, gives out 3 branches to the head and to the arms, and then curves down through your chest, through your diaphragm, into the belly, into the abdomen, and then branches off into 2 iliac arteries that go to your legs. So today I will just focus on the thoracic part. That is the part of the aorta that sits in your chest. Cardiac surgeons basically take care of this part of the aorta. If we talk about the abdominal aorta, it's basically vascular surgeons that offer surgery or endovascular surgery for this part of the aorta. So looking at this cartoon, we can divide the aorta into some segments that helps us in the hospital to communicate a bit easier about certain parts of the aorta. The first part would be the aortic root. So the aortic root involves the aortic valve that sits in between your heart and your aortic root. And basically the aortic valve is usually a tricuspid valve. That means it has 3 leaflets, and it opens, lets blood through, and then it closes to make sure that there's no blood going to the wrong direction. There are 2 branches called the coronary arteries, a left one and a right one, and they supply the heart muscle with blood and oxygen and nutrition so that the heart can beat and contract. The next segment would be the ascending aorta. That is basically just a tubular segment that leads the blood further into the aortic arch. And the aortic arch is the horizontal part of the aorta that has 3 branches. On the left side, you can see the innominate artery, or the brachiocephalic trunk. This part divides up into 2 arteries. One artery that goes up into your head and your neck and supplies the head and the brain with blood, and one artery that goes into your right arm. This is called the right subclavian artery. And then we have a left carotid artery that supplies the left part of your brain, and the left subclavian artery that supplies your right arm, left arm. It's pretty difficult with left and right. The next part is the descending aorta. This part goes down just next to your spine and has some tiny branches that branch off to supply the spine and the chest wall, and then the aorta enters the diaphragm and becomes the abdominal aorta. So now that we have learned a little bit about the normal anatomy, we can talk about pathological changes. And basically, if we talk about the thoracic aorta, there's usually one major disease or one major thoracic aortic disease, which is an aortic aneurysm. Aortic aneurysm means that the aorta or the blood vessel is enlarged. Usually we talk about an aneurysm when it reaches like 1.5 times the diameter of the normal or expected diameter. The aorta has a diameter of about 1 inch, that's 2.5 to 3 centimeters. And once it becomes 4 centimeters, we would call it enlarged or dilated. And starting at a diameter of 4.5 centimeters, we would call it an aortic aneurysm. There are a couple of different variations or types of aortic aneurysm. On the left side, we see the normal aorta. And then the second picture shows a so-called ascending aortic aneurysm. That means that the ascending part of the aorta is enlarged. The third picture shows you a root aneurysm. Remember, the root is the first part of the aorta, and if this part is enlarged, we call it an aortic root aneurysm. And then there's also types of aortic aneurysm that have a dilatation of both segments, and this would be called a tubular aneurysm. There's also aneurysms of the aortic arch. That is the part that branches off with 3 arteries to the arm and to the neck and the head. That would be an aortic arch aneurysm, shown here on the left side. And we have aneurysms of the descending aorta, shown on the right side. How common is that? Actually, you don't hear about it a lot in the media because there are other diseases that are way more prevalent and common. Everybody knows some family members or relatives who have a heart attack or a stroke. It's not that common to hear about aortic diseases, but it's actually not that uncommon. So every year in the United States, there are about 15,000 patients that get affected or get diagnosed with a new diagnosis of thoracic aortic disease. And about 47,000 patients die per year in the United States from aortic disease. And that is more patients that die than from cancer or other diseases, or breast cancer, not cancer in general, but breast cancer or HIV, because these diseases can be treated well, but aortic disease can be very tricky at some point. That is why it's often referred to as a silent killer or silent epidemia, because many patients don't know about these diseases, as we have heard today. Sometimes the diagnosis is just made up very quickly in the emergency department, and patients learn about their diseases very abruptly in some cases. What else can we say about this? I think like men are usually more affected by this disease than women, like 2 to 4 times more commonly than women. And usually patients get affected by thoracic aortic disease in their 60s and 70s. What are the reasons for aortic disease or thoracic aortic disease? So maybe the most important reason or cause for aortic disease is high blood pressure, hypertension. Hypertension can lead to atherosclerosis of the wall and to degeneration of the aortic wall, and the wall can get thinned out, and this can lead to aneurysmal growth. So blood pressure is really a big thing and maybe the #1 reason for aortic aneurysm disease. There are other diseases that we have also heard of today. This is a picture from one of my favorite movies when I was a child. That's Star Wars, and that's Han Solo and Chewbacca. The actor of Chewbacca is Peter Mayhew, and he is actually a tall guy. He is 7.1 tall, and I think he passed away recently, and he has a genetic defect called Marfan syndrome, and this syndrome leads to a dysfunctional fibrillin protein, and this leads to a connective tissue disease problem, and those patients who have Marfan syndrome often are very tall, they have long fingers, they can have problems with their eyes, their joints, and also have very often problems with their heart or their aorta, and often those patients have aortic root aneurysm. There's another famous person who has a congenital defect, that is Arnold Schwarzenegger. He had a bicuspid aortic valve, and he underwent multiple surgeries for that. I think the most recent one was done 2 or 3 years ago at the Cleveland Clinic. First, he had a so-called Ross procedure, and then his valve failed, and then he needed redo surgery, and he is still doing well. Normally, as I said before, an aortic valve has 3 leaflets that open and close to let the blood go through and prevent the blood from going into the wrong direction. A bicuspid valve means that there's only 2 leaflets, or 1 or 2 of the 2 leaflets out of the 3 leaflets are fused. And this is a very common congenital defect. About 1 to 2% of the entire population of this planet have a bicuspid aortic valve, and so it's actually not that uncommon. So what is the problem with aortic aneurysms? They are very asymptomatic for a long time. Many patients don't know that they have a problem with that, and that is basically the critical thing, because when the aneurysm is there, the patient doesn't have any problems, but when it grows and grows, it can tear or rupture. If the aneurysm tears, we would call it an aortic dissection. We have heard that term before today, and this is the worst complication that could arise. And if the aortic dissection is located at the ascending aorta or in the ascending in the aortic root, this would be a medical emergency that requires immediate surgical treatment. If the dissection is located in the descending part, it can often be managed medically, but it's still a medical emergency. So that is the only reason why we operate on patients that don't have any problems or symptoms, just to prevent aneurysmal growth with dissection or rupture. That brings me to the next point. Oh, dissection, that is actually a nice picture. So what is an aortic dissection? That means there's a tear in the innermost wall of the aorta. The aorta has 3 layers, an inner layer, a middle layer, and an outer layer. And if there's a tear in the innermost layer, blood can crawl into the wall and then lead to a disruption of the entire aorta. How can we treat these diseases? So basically the surgery for elective cases, that means prophylactic, or for emergent cases, is more or less the same. We offer the same surgery, just at a different time of the disease. And usually the surgery that we can offer is determined by the segment of the aorta or the anatomy of the disease process. In this picture, you can see an ascending aortic aneurysm. That means this part is dilated, and we can just treat it with an ascending aortic replacement. The patient is under general anesthesia. He doesn't feel any pain or just sleeps. Then we would open the chest and put his body or her body on a heart-lung machine. The heart is arrested for about half an hour or 60 minutes, and then we take out that enlarged part and replace it with a tubular graft. That graft is sutured into with sutures at the bottom and at the top, and then the heart is beating again. We turn off the heart-lung machine, the heart takes over, and then we could close the chest, and the patient goes to the ICU. These operations take nowadays maybe 3 hours. That's for us a straightforward operation that can nowadays be offered very safe. 50 years ago, it was a big procedure. I remember my previous chief from Germany, he told me when he was a resident, I mean, they were happy at that time when they brought a patient through that operation alive. Nowadays, these operations can be offered in a very safe way with mortality of less than 1%. So we made a big progress in the last 40 years to offer safe surgery. Let's say the ascending aorta is enlarged and the aortic root, then we have to offer a different kind of surgery. If everything is enlarged, we have to offer a complete root replacement. This is shown on this slide. So we replace the ascending aorta, the aortic root, and also the aortic valve. The aortic valve is replaced with a mechanical or a tissue valve prosthesis, and the coronary arteries are reimplanted into that straight ductile tube graft. When it comes to mechanical valves or tissue valves, that is a big and important choice for every patient. We have heard about mechanical valves today and tissue valves. They offer different advantages and disadvantages. And just to sum it up quickly, usually young patients are offered or recommended a mechanical valve prosthesis. The reason for that is that they last a lifelong. They can last 40, 50 years. The only downside is that you need to be on a blood thinner called Coumadin or warfarin that requires a bit more of attention and lifestyle changes. Older patients are often recommended a tissue valve prosthesis that is shown here on the right side. These valves have a limited lifespan of, let's say, 10 to 20 years, but for most patients above 70 or 80, that's a better choice because that will valve for the rest of their lives. They can avoid a blood thinner, and that's why we often recommend this valve type to older or elderly patients. There's also ways of preserving the aortic valve. That is it's not new, but it's a more modern surgery of root replacement. If the valve is structurally intact, we can try try to save it and offer so-called aortic valve root replacement. The procedure is a bit more complicated, but the major benefit is that the patient can keep his own valve or her own valve, and that can be offered in special cases when the valve is not stenotic, that means blocked or narrowed. These were diseases of the ascending aorta and the aortic root. This picture here should just depict like surgeries that are offered for aortic arch aneurysms. That means the part that gives off those three branches to the head and to the arm. We have nowadays hybrid procedures where we can insert a stent graft from the groin and replace the aortic arch with a Dacron graft. That is called a hybrid repair. Early on, let's say 20 years back, we didn't have these techniques, but nowadays they are pretty standard, and it makes surgery way quicker, and that is in the end beneficial for the patient because it's less traumatic and quicker. So how safe is surgery? I said like 50 years ago, it was like more or less, I don't know, challenging and experimental. Nowadays, we have made a huge progress. This is data from the Cleveland Clinic for their outcome, and they can offer, or most hospitals nowadays offer surgery in a very safe way. And of course, it's dependent on the procedure that we talk about, but ascending aortic replacement or aortic root replacement can usually be offered with a perioperative risk of below 1% or 1 or 2%. And that means there's basically 99 or 90% chance that the operation will go very smoothly without any complications. What can we expect after surgery or in the first days there? So that is again Arnold Schwarzenegger after his most recent procedure. I think he Twittered that picture, so he looks quite happy. Maybe he's still on some painkillers or drugs, I don't know. But actually most patients do pretty well. Usually with straightforward or elective operations, you will expect to stay one night on ICU, and already on the next morning you are transferred to the telemetry floor, and the usual hospital stay is about 5 to 6 days. Young patients sometimes go home on day 4. Some elderly patients may stay in for 7 or 8 days, but usually it's about 5 to 7 days. Elderly patients sometimes, take the offer of going to a rehab center for a couple of days to recover there, which is a great option. And usually after, I would say 1 month or 2 months, most patients are back to normal. Of course, that also depends on the age and every patient's status and functional status, but usually after 2 months, I would say patients are back to normal. There's also other things that we can offer or try to help every patient to get back quicker to their feet. I would say like 20 or 30 years ago, most surgeries were done with a full sternotomy. That means we opened up the entire chest here or the entire breastbone. Nowadays, we can offer most surgeries with a so-called hemi or mini sternotomy. That means we open up only the upper part of the breastbone, and we can actually offer most aortic operations that affect the aortic root or ascending aorta with a mini incision. And the incision is only about 2 inches long, and that also means that the recovery process is way quicker. Like studies have shown that the pain is less, and patients usually have a shorter hospital stay and also can leave the hospital 1 or 2 days earlier. What can you expect after discharge? Usually there's cardiac rehab, and usually the insurance companies have no problem offering that after open heart surgery. Usually after 2 or 3 weeks, you can expect to go to cardiac rehab. That takes place 2 or 3 times a week. And there's diet recommendations, lifestyle recommendations, and also, of course, physical exercise. On the long term, I often hear the questions, what can I do after cardiac surgery? That is a bit, of course, different for every single patient. If you have a dissection or residual dissection, it might be different. But let's say you just come in for an aortic valve replacement or an ascending aortic replacement and there's no disease left, you can basically do whatever you want because everything that was wrong has been taken care of and is treated. And I tell my patients they can go on flights, they can go on cruises, they can do bungee jumping, whatever they want. So once everything you have recovered from that, you can do whatever you want. But of course, if there's a dissection left or anything else, it might be different, but most patients can do whatever they want. So some take-home messages that I just try to put together. Thoracic aortic aneurysms often remain asymptomatic. The keyword was like silent epidemic. Many patients are affected by it. However, there's a major complication that is called aortic dissection, and that is a medical emergency. Most patients require immediate treatment if they have a dissection or even immediate surgery. That's the reason why we offer prophylactic aneurysm repairs for patients who are even asymptomatic and don't have problems to avoid aortic dissection and further complications. There are different surgical approaches that are always tailored to the individual patient. And in the end, I would say that cardiac surgery and open heart surgery for aortic disease is nowadays a very safe procedure that provides very durable outcome. Thank you.